I'm going to speak a little bit about management of anterior glottic webs, specifically acquired anterior glottic web. We'll talk a little bit about congenital, but Dr. Thur did a great job of talking about that earlier. So without further delay, I have no relevant disclosures. Specifically an outline for what we'll talk about today, like I said before, anterior web, how it affects the phonatory and physiologic aerodynamics, pathogenesis of the web, as well as management. And specifically, we'll talk about laryngoplasty as a way of endoscopically managing these webs. And then finally, we'll talk about adjuvant treatment that's been discussed in the literature and how to address them post-operatively. So, as has been mentioned earlier, there are two forms. There is congenital form, or there is a acquired form. Anterior webbing is typically the scarring, as you all know, between the front of the vocal folds. It basically is in laryngeal congenital abnormalities. It makes up about 5% of that group. It typically involves at least the first third before it becomes pathologic. However, it can involve anywhere between a small portion all the way up to the entire vocal cord. Typically, the scar that forms has to form as a result of two raw surfaces. So typically, you'll see it in the setting of intubation, or you'll see it in the setting of surgery or some other manipulation of the larynx. But it can happen in a number of scenarios. It can either happen after RT, prolonged intubation, as has been mentioned by Dr. Bolmick. It can happen after trauma, as well as inflammatory diseases or infection. Very important to identify whether or not this is malignancy in patients that have no history of the former, of the aforementioned causes. So if you see a web that's de novo and the patient has no other history of intubation or surgery, you want to have a high index of suspicion for possible cancer. In a series looking at patients that had total transoral laser microsurgery for glottic cancer, about 9.4% of them had webbing after their surgery, and about 1.9% of them were symptomatic. Congenital web, as has been mentioned earlier, forms as a result of a disruption in the normal autolysis of the laryngeal tracheal groove during the 10th week of embryogenesis. These congenital webs have variable morphology, and as has been mentioned before, there's a classification that describes that morphology from class 1 or type 1 to type 4. Usually, it's sort of more of a form of laryngeal atresia, and the webbing can be either thick and fibrotic if it's more of kind of a class or type 3 or 4, or it can be thin and a little bit more easy to manage if it's type 1. It should be noticed that the bulk of what I'll focus on are the acquired webs. So specifically, physiology and phonatory aerodynamics of webbing. So when you have an anterior glottic web, you have disruption of the normal trajectory of airflow through the glottis. What that causes, what that is associated with is a blunted anterior angle, and what that causes is a lower projection and intensity of the sound. You can also have pitch discrepancies because the vocal fold itself is shorter rather than what you'd expect to see. It can change the timbre and the resonance. For the most part, these characteristics are perceptible on physical exam. You can hear a thinner voice and a higher pitched voice, but occasionally you can't. And so you have to do a preoperative, of course, stroboscopy. Now, with any patient that's identified with a web, you'll need to kind of make sure that your stroboscopy is thorough, meaning that you have to not only evaluate the web from above the vocal folds, but you have to do a subglottal evaluation of the vocal folds to determine what is underneath the web. As I mentioned before, neoplastic causes of webbing can happen, and you want to make sure that you're not missing an occult malignancy that hides just underneath the web. It also can give you a sense of the remnant superficial lamina propria by doing an appropriate stroboscopy in your initial evaluation. Voice measures can be helpful as well, especially if you're considering operative intervention for these patients. And aerodynamic assessments can also be helpful as well when you're considering surgery to address the web. So what's the best way to stay out of trouble is avoid trouble. So if there's a way that you can prevent web, say if this is a case-based series, so say that you have a patient with papilloma who's had a number of treatments throughout the course of their disease. Rather than actually treating both sides anteriorly and allowing a web to form, the best thing to do is to prevent a web from forming in the first place. So one thing you can do is you can stage a resection. If you have papilloma where disease is along both anterior parts of the vocal fold, you can leave a little bit of papilloma behind and come back about 2 months later and treat the papilloma at a subsequent surgery. You can also potentially consider injection of adjuvant either steroids or mitomycin C, but the supportive evidence for this is pretty weak. Or you can perform a flap at the time of surgery, and we'll talk about this in just a bit, what the flap entails. Post-operatively, I always wondered why certain people develop webs and why other people are seemingly free of developing anterior glottic webbing. And I've noticed that patients that tend to trend towards glottic guarding during stroboscopy tend to keep their vocal cords a little bit more adducted, and those patients are the ones that I see developing webbing more so frequently than others. And so what I've encouraged patients to do, and I've had great success with, is encouraging patients to perform actually respiratory retraining exercises as they heal from surgery to decrease the risk of webbing, and it's actually worked pretty well. So in terms of management, there are a number of different options. I'll briefly get into the management for how to treat anterior glottic webbing. There are multiple approaches. Voice therapy, obviously low-hanging fruit. It's easy to approach. It has no invasive component, and it can oftentimes help patients if they're concerned about the pitch of their voice, but it doesn't really get rid of the underlying problem, again, because it doesn't change the anatomic structure that's causing the problem in the first place. After this, we'll talk about some of these other options. We'll talk about some of the surgical options as well as the adjuvant options. So with regard to surgery, resection is an option for anterior glottic webbing. It's ill-advised, it has high recurrence rate. Unfortunately, additionally, resection can lead to other problems. For patients that have an over-resection of their webbing, you can have a significant loss of the superficial lamina propria, which can create scarring, as has been mentioned earlier, and can create a significantly dysphonic voice. Additionally, if laser is used to resect the web, it sometimes can be difficult to identify these tissue planes, and you can have subsequent problems identifying occult malignancy or dysplasia if there is some. So my workhorse for anterior glottic webbing is laryngoplasty. So what I do is actually a rotational flap, and we'll get into that in just a bit, but there have been a number of ways that people have described using various flaps to decrease your risk of webbing. So we'll talk about that in just a bit. The reasons why you want to address this surgically is that you can improve architectural anatomy, which can oftentimes allow you to identify recurrent disease in the future, specifically in the case of papilloma, can enhance voice quality, and it can also, for men, allow for a pitch to be a little bit lower by extending the length of the vocal folds. So briefly, again, patient comes in with a laryngeal web. This is a patient that's had prior papilloma, and you can see on their stroboscopy, as well as using NBI, that you can see the normal kind of papillary changes that you see in papilloma typically. It may be helpful for you while you're doing this type of surgery to use a right angle probe to determine what the length of the web is endoscopically, to use a 70-degree scope so you can get a full evaluation of the web from below, and then also for you to consider using a cord spreader, as has been mentioned earlier, to give yourself the ability to have the tissue under tension, which tends to cut easier and also suture a little bit easier when you're endoscopically working. So there are different approaches. The first one that I'll talk about is a turn-in flap, a laryngoplasty with a turn-in flap. So essentially what's done here is you're making a small incision along the superior aspect of the anterior glottic web. You're denuding that epithelium and you're saving it for subsequent turnover. You're removing a fibrotic component of the anterior web, and then you're saving the inferior component of the epithelium, and you're turning that over on the contralateral side. This involves suturing on both sides and is a little bit more complicated than if you were just to suture one vocal cord or one side. So this tends to be a little bit more work than if you were to do just a rotational flap. There's a series of 11 patients that underwent this procedure. I'm sorry, it's a little bit small here, so you can't really see it, but most of them were resected with a CO2 laser. It demonstrated that the patients had a pretty good quality of life, as well as voice quality, after 3 months after this flap was placed. The problem is the laryngoscopy demonstrated that there still is some degree of webbing that exists there in this paper. That being said, the patients did receive an improvement in their VHI as well as in their perceptual measures. So moving on to a rotational flap, again, this is kind of the workhorse for me. This is what I use most commonly. And many have described their experience using rotational flap. My mentor, Stephen Zeitels, discussed 53 patients that he treated with rotational flaps for anterior glottic webbing. And he talked about the technique a little bit. The first thing you want to make sure is that you have a scope that it gives you the appropriate visualization and exposure of the anterior glottic web. So I use a universal modular scope, glottoscope, that actually helps address and access the anterior glottic web. You want to make sure that you're using elevated vector suspension, which actually gives you the best exposure of the anterior glottis. Finally, you want to make sure that you are using a cord spreader to put the mucosa under tension. And then oftentimes saline or saline with epinephrine can be helpful in not only decreasing bleeding, but also identifying what residual lamina propria is left. And then a lysis of the web can be performed with strategic placement of the incision. Finally, using a suture such as a 6-0-proline or 6-0-PDS and a BV1 needle, which is actually an ophthalmologic needle, can be helpful for placing these sutures endoscopically. So one thing before we get started, as Dr. Castellanos mentioned, endoscopic suturing can be a headache and it can drive you insane. Fortunately, I'm not yet insane, but I still have a long career ahead of me. The one thing that's helped me in terms of endoscopic needle placement is actually bending the needle before it goes in. So I use a BV1 needle, which is, like I mentioned, an ophthalmologic needle, but I bend it slightly to increase the turn, the angle of rotation that I have. So what you're doing with any web surgery is that you're taking your web, you're taking your larynx, you're going from superior to inferior, you're placing your needle in the infracortal or the subglottic area, and you're pushing it back out through the anterior commissure itself. And what that does is it creates a spear with which you can put other rotational flaps, and it allows you to actually suture things down a little bit more easily, and then you use slip knots to tie everything down. And it works pretty well, actually. So briefly discussing the options here for flaps. The first one that has been very helpful and can be very useful is a rotational flap. So in this series of pictures, rotational flaps being performed, similar to the turn-in flap, you can see in Series A, or picture A and B, that there's this cicatrization between the right and left vocal fold. What's done is in Series C is actually very important. In panel C, there's being an injection of saline into the native vocal fold, which demonstrates an expansion of the superficial lamina propria and actually allows you to appropriately preserve your native vocal fold while not cutting into it, while cutting into the webbing. So what you're doing is you're following along this line between native vocal fold and web to make your incision, and then you're incising and you're suturing the remnant web to the other side to create a flap. And this works actually pretty well to decrease your risk of having recurrence. Another, Jonathan Lahav from Israel, I identified another kind of area that you could harvest from for a rotational flap. He uses the subglottis rather than the web itself. And so he resects the web. He then, this is sort of the two raw edges, he then harvests by elevating a subglottic flap and then rotates it into one or the other vocal fold and sutures it there. And that actually works pretty well. The problem is there's not as much laxity of the subglottis compared to, say, the anterior web. And so you can sometimes have difficulty suturing that and can drive you crazy. You can see here the suture job here is a little bit tight and it doesn't really kind of flow as well as we would hope. So what I use more typically is actually a supraglottic rotational flap. And what you can do is, because there is so much redundant mucosa on the false vocal fold and the supraglottis, you can actually outline a flap from the supraglottis that's pedicled anteriorly. You leave this pedicle here and you outline a flap that you can cut with standard micro mini scissors. You can then rotate that flap down into the anterior commissure, and you have to make sure that the mucosal side is abutting the contralateral scar so that it doesn't heal in or scar in. You suture in by using the same technique we talked about, putting your needle in through the anterior commissure. You use the needle as a spear to impale the flap, and then you suture it down, and it should look something like this when you're done. In this paper, they've actually used a hypodermic needle, but this is very easily done endoscopically as well. You want to make sure that your flap is bleeding when you place this, and it's sort of just important, and patients usually heal up pretty well after that. And the last way of closing an anterior commissure web is actually doing a suture closure of the raw surfaces on the ipsilateral vocal cord. So you can see here, this is the web here. There's been an incision made on the right fold, or the right aspect of the web, and then actually your suture is being placed just through the right part of the web. What it does is it creates this raw surface that then closes in on itself, allowing you to maintain that length to your vocal fold without potentially sacrificing superficial lamina propria. And you can see it heals very well, and you still preserve superficial lamina propria, which is very vital. So finally, you can use the disease itself. So this is an example of using papilloma after you free it up and pulling the papilloma anteriorly and suturing it to the anterior commissure to extend and preserve your length. The papilloma is then treated at a separate time, about 3 months later, to get rid of the remnant disease that's there while preserving your length and maintaining a good voicing outcome after papilloma. Keel placement's already been mentioned wonderfully by Dr. Thiru, so I'm not going to spend too much time on that. I find it to be a little bit more technically challenging, and I also find it to be a little bit more causative of sometimes granulation tissue, so I'm not going to spend too much time on that. But the other thing that needs to happen as well is that sometimes the keel has to be removed at a later time, either in the OR or in the clinic. Then finally, this is a series that looked at keel placement for anterior glottic web. And finally, since I'm almost out of time, I'm just going to briefly talk about some adjuvant treatment for patients that have web. Specifically, mitomycin C, hyaluronic acid, and others have been proposed. This is a paper that evaluated the use of mitomycin C and fibrin skin glue to decrease the risk of webbing. Unfortunately, the data did not really suggest that there was an improvement in webbing after use of mitomycin C. There was some reformation that occurred. And then finally, another paper, basic science paper, translational paper, looked at hyaluronic acid derivatives to decrease the risk of web formation and found that the web actually decreased, or web formation decreased after use of hyaluronic acid compared to mitomycin C. So this is mitomycin C. You can see the web comes back. This is a control. This is a rabbit larynges. This is control. This is mitomycin C. This is hyaluronic acid derivative. And you can see there's a little bit more of a improved glottic angle there. And this was bore out in terms of the length of the web relative to the length of the cords. This is somewhat improved relative to control, but maybe equivalent to mitomycin C. So with that, that's all the time I have, and I thank you again for your attention.